Hello everyone, I'm Dr. Surekha Davar, second year postgraduate from Department of Oral and Maxillofacial Surgery. Today we'll discuss about maxillary sinus and its complications. The contents of the seminar will be introduction, development and anatomy of maxillary sinus, blood supply, nerve supply and lymphatic drainage, histology, functions, diagnosis, and the complications of maxillary sinus, which includes maxillary sinusitis, oroental communication and fistula, and their management. The paranasal sinuses are air-filled spaces located within the bones of the skull and facial bones. They are centered on the nasal cavity and have various functions, including lightening the weight of head, humidifying and heating inhaled air, increasing the resonance of speech, and serving as a crumple zone to protect vital structures in facial trauma. The four sets of sinuses are paired, and they are frontal sinuses, sphenoidal sinus, ethmoidal sinus, and maxillary sinus. We'll discuss maxillary sinus in detail. Maxillary sinus is a pneumatic space that is lodged inside the body of the maxilla and that continues with the environment by the way of middle meatus. It is the first sinus to develop. Maxillary sinus starts with a shallow groove on the medial surface of the maxilla during fourth intrauterine life and reaches to maximum at around 18 years of age. The expansion of maxillary sinus occurs more rapidly until all the permanent teeth have erupted. At birth, the maxillary sinus is an oblong cavity which is tubular in shape. In the early childhood, the floor of the maxillary sinus is above the floor of the nose, and the teeth develop. The growth of alveolar process takes place, and the floor also starts descending down. At around 12 years of age, the floor of the sinus is at the level with the floor of the nose, and in adulthood it becomes pyramidal in shape. The anatomy of maxillary sinus was given by Highmore in 1651, so it is also called as antrum of Highmore. It is the largest of all paranasal sinuses and communicates through nasal wall. Horizontal, pyramidal shaped with base, apex and 4 walls, so in total it has 6 walls. The anterior wall of maxillary sinus is formed by facial surface of maxilla. The posterolateral wall is formed by zygomatic and greater wing of sphenoid bone. The medial wall is formed by lateral nasal wall. The floor of the maxillary sinus or the inferior wall is formed by alveolar process of the maxilla carrying the roots of molars and premolars. The superior wall is formed by the roof of the sinus and floor of the orbit. All the walls can be clearly seen in this picture. The posterior-superior part of the lateral wall in the inferior meatus is the thinnest area and is preferred site for nasal enterostomy. The blood supply of the sinus is from facial, infraorbital, and greater palatine vessels. Pterygoid venous plexus, sphenopalatine vein, and facial vein controls the venous drainage of the maxillary sinus. Nerve supply to the maxillary sinus is majorly from the posterior, middle, and anterior superior alveolar nerves, which are branches of maxillary division of the trigeminal nerve. Infraorbital nerve and greater palatine nerve also contributes to the nerve supply of the maxillary sinus. The lymphatic drains into submandibular lymph nodes and deep cervical lymph nodes through infraorbital foramen or ostium. The sinus depends on the action of the cilia for its drainage. The lack of ciliary action leads to stasis of secretions, which leads to infection of maxillary sinus. Maxillary sinus is lined by the 3 layers, that is epithelial layer, basal layer, and subepithelial layer with periosteum. The rhythmic beating of the cilia is responsible for the drainage of sinus against the gravity. The epithelium is pseudo-stratified columnar and is ciliated in nature. The functions of maxillary sinus are humidification and warming of air, assisting in regulating intranasal pressure. It helps in lightening the skull to maintain proper head balance. It imparts resonance to the voice, absorption of shock to the head, and the filtration of the inspired air. The clinical examination of the maxillary sinus can be done extraorally, intraorally, or through transillumination test. In extraoral examination, we check for pain and tenderness and swelling over the cheekbone. In intraoral examination, we check for pain and tenderness over the maxilla between the canine fossa and zygomatic buttress. Good transillumination indicates the presence of air in the sinus, while the failure of transillumination indicates the presence of pus, fluid, solid lesion, or mucosal thickening. Radiographs are the most important investigation to examine the sinus. The intraoral views we use for maxillary sinus are occlusal views, periapical view, and lateral occlusal view. The extraoral views are occipitomental view, Waters view, lateral skull, orthopentamogram, and computed tomography. Now the complications of maxillary sinus. Maxillary sinusitis is the inflammation of the mucosa of the paranasal sinus. It is usually odontogenic in origin because of close approximation with maxillary teeth, and it occurs secondary to allergy or infection. The sinus lining becomes edematous, inflamed, and congested, which leads to excessive secretion of mucus, loss of ciliary action, stasis of secretion, and secondary infection. The exposure of sinus during trauma may also lead to sinusitis. A chronic periapical infection leads to destruction of intervening bone, and infection may enter the sinus. The destruction of the floor of the sinus by tumors can also lead to the infection of the sinus. Maxillary sinusitis can be acute, subacute, or chronic in nature. In acute, it is of sudden onset and the duration of 4 weeks. In subacute, the duration is of 4 to 12 weeks. In chronic, the duration is of 12 weeks or more than that. So this is a picture showing healthy sinus and sinusitis. In the case of sinusitis, you can see inflamed sinus lining, whereas on the other side, it's perfectly normal. Excess mucus secretion or sinus infection can be seen on the affected side. The etiology of maxillary sinusitis: mostly it is due to infection, which can be due to periapical abscess spreading into maxillary sinus, fungal sinusitis, ciliary dysfunction, trauma, fracture of antral floor, allergy, tumors or cyst, antral communication and fistula, displaced tooth or tooth root, overextension of dental materials like gutta percha or cements or sealers. The signs and symptoms of maxillary sinusitis are impairment of sense of smell, foul smelling of mucopurulent discharge in nasal cavity, herniation of polyp into middle meatus, prolapse of polyp through the fistula, facial pain or pressure, facial fullness, nasal obstruction, headache, fever, halitosis, and ear pain and cough may be encountered in some cases. Now the treatment line will be: first we will treat the cause, plenty of fluids and bed rest will be given to the patient, maintenance of oral hygiene, antimicrobial therapy, nasal drops or sprays are advised, analgesics and inflammatory drugs are prescribed. Next is oroantral communication. Communication between the maxillary sinus and the oral cavity is termed as orodental communication. It is one of the complications which can occur when doing extraction of upper molars. This is a picture showing orodental communication. In the first case, it is on the maxillary region, and in the second case, it is on the labial surface of the maxilla. Now, the etiology of orodental communication. Tooth extraction was the most common etiological factor. Maxillary molars, roots in close proximity to the maxillary sinus, destruction of the portion by the periapical lesion, little or no bone between the maxillary sinus or tooth, plunging an elevator through the bony floor during the root tip removal can be the cause, forcing root tips or tooth into the sinus, penetration while exposing impacted tooth, perforation during incorrect curettage, fracture of any segment of the alveolar process containing one or many teeth with tearing of the floor of enterum can be the cause. These are the radiograph and picture showing close proximity of periapical lesion to the maxillary sinus floor, which increases the risk of orodental communication during debridement of socket. In the first case, the roots of molars are in very close proximity to the floor of sinus. The symptoms are the 5 E's, which describe escape of fluids, epistaxis, which is unilateral most commonly, escape of air, enhanced column of air, or the excruciating pain. The 5 P's are pain, which is mostly encountered in infraorbital region, persistent purulent nasal discharge from the affected nostril, especially when the head is lowered down, post-nasal drip, that is the trickling of nasal discharge from the posterior nares down the pharynx, popping of antral pathology orally, and phonation problems. The tests: tell the patient to fill his mouth with colored water. Colored water we prepare with water mixed with few drops of gentian violet and let him bend forward and downward. If there is an oral enteral communication, it will flow through the nose. If communication exists, there will be passage of air through the tooth socket and bubbling of blood in socket on blowing air. Now the prevention. Firstly, radiographic examination of the region surrounding the tooth to be extracted. That is specially advised in cases of maxillary molars. Careful manipulation with the instruments, especially during the luxation of the root tip of a maxillary posterior tooth. Avoiding luxation of the root tip if visualization of the area is hindered by hemorrhage. Careful debridement of the periapical lesions that are close to the maxillary sinus. The management part is, if the communication is 2 mm or less, if the communication is 2 to 6 mm in diameter, and if the communication is larger, that is 7 mm or more. In the first case, there will be no surgical treatment. We'll just ensure the formation of high quality blood clot and will advise sinus precautions. In the second case, when the communication is 2 to 6 mm in diameter, will ensure the maintenance of blood clot. Figure of 8 suturing will be done over the socket, will advise the sinus precautions, and antibiotics, that is amoxicillin or clindamycin, will be prescribed, will put the patient on follow-up. When the communication is 7 mm or more in diameter, surgeon should consider having sinus communication repaired with the flap procedures. Flap can be local or distant, which will be discussed in detail. Most common for small opening, that is buccal flap or palatal flap. The sinus precautions that we advise to the patient are: the patient should not drink with straw, do not blow through nose, use all the medications as directed by the surgeon, do not play any wind instruments which requires additional pressure, do not smoke cigarettes, pipes, cigars, do not sneeze through your nose, avoid swimming or any strenuous exercise for at least 1 week, eat soft diet and chew from opposite side, rinse 3 times a day with warm water, it's not uncommon to have a slight amount of bleeding from nose for several days. The next complication is oroenteral fistula. If an oral enteral communication is not treated, this can become lined with epithelium. Hence, an oral enteral fistula is an epithelialized trap linking the maxillary sinus to the oral cavity. It's the chronic version of the acute communication of the maxillary sinus into the oral cavity. It facilitates the regurgitation of fluids from the oral cavity into the maxillary sinus and contamination of the sinus with the oral microbial flora, which leads to chronic sinusitis. This is the clinical picture showing an oroenteral fistula. In the first case, it is on the maxillary ridge, and in the second picture, metallic probe is inserted inside the fistula. Temporary therapeutic measures before the surgical closure includes Whitehead's varnish pack. The pack is used over a socket and secured with suture. Whitehead's varnish composition is benzoin, storax, balsam of tolu, iodoform, solvent ether. Or a denture plate can be used. Denture plate is indicated when surgical repair of fistula is to be deferred. It provides barrier to prevent entry of food particles into the maxillary antrum. The management. Before closure of the oroenteral fistula, it is imperative to eliminate any acute or chronic infection within the sinus. This may require frequent irrigation of fistula and sinus combined with the use of antibiotics and nasal decongestants. The management of oroenteral fistula by flaps. In buccal flaps, we use Rahman's flap and Moxey's flap. In palatal's flap, Ashley's pedicle flap, palatal rotational advancement flap, and pedicle island flap. Regional flaps can be tongue flap, buccal fat, or cheek. Distance, we can use temporal muscle fascia for the distant flap in closure of oroenteral fistula. The bone grafts are also used. Alloplastic materials such as elastic titanium obturators can be used. The Rahman's buccal flap. In case of Rahman's buccal flap, it is a broad-based flap, and rather than the periosteal scoring, liberal undermining is done to advance the flap, which results into the obliteration of the buccal vestibular depth. This periosteum is incised, and then the defect is closed. This is trapezoidal sliding flap, that is Moxey's flap. It is also described as buccal sliding trapezoidal for closure of alveolar fistulas. The change in the vestibular sulcus is negligible by shifting the flap one tooth distally. The main disadvantage of this flap being that it necessitates greater amount of dento-gingival detachment in order to facilitate the shift. The distal shifting of the flap covers the oroenteral fistula, but it leaves the gap or defect medially on the buccal vestibule. As the raw area lies on the healthy bone, it heals uneventfully by granulation and subsequent epithelialization. The next is palatal island flap, which was given by Brosh in 1950. In this palatal island flap, it is used for closure of oroenteral defect, and it can be used in closure of larger fistula. It's a one-stage local procedure that provides a flap with an excellent bulk, a good blood supply, and mobility. Necrosis of the palatal bone of the donor side is not a problem with this procedure, as there is ample blood supply from the nasal mucosa. This procedure is suitable for the closure of posterior fistulas because it's pedicled on the greater palatine vessels. Its application is limited in closure of anterior defect only. Next is palatal rotational flap. This technique, in contrast, provides adequate mobility and tissue bulk to the flap. It requires the mobilization of large amount of palatal tissues. The flap often kinks following the rotation of the flap and cause venous congestions. Now, Cadwell-Luke operation. It was given by George Cadwell in 1893 to gain entry into the maxillary sinus. The indications for Cadwell-Luke operation is: first is removal of tooth root from the sinus, removal of any cyst, tumor or polyp, management of active bleeding from nose, removal of impacted canine or third molar, zygomatico-maxillary fracture during the floor of orbit. The procedure is: first, a semilunar incision is made in buccal vestibule from canine fossa to the second molar region. A full thickness mucoperiosteal flap is elevated using periosteal elevator till infraorbital region. An opening or window is created in anterior wall of sinus with help of chisel or dental drills. Opening is enlarged using Ronger forceps to permit proper inspection into the maxillary sinus. The pus is sucked away from the sinus and thorough irrigation should be done using saline water and betadine. Removal of tooth or tooth root is done. The thickened infected lining of the sinus is elevated using Howard's periosteal elevator and is removed. If profuse bleeding is there, then pack in the sinus with ribbon gauze soaked in adrenaline for 2 to 3 minutes. Enteral cavity is again cleaned and packed with iodoform pack and suturing is done. Watertight suturing is done in case of Cadwell-Luke operation. Antibiotics, analgesics and anti-inflammatory are given for 5 days. Pack is removed on 5th day. Benzoin inhalation should be given for 3 days followed by nasal drops. Patient should be instructed not to blow nose and have soft diet and avoid vigorous gargling. This is the diagram showing Cadwell-Luke operation. It's showing the site of opening, which is above the premolars and molars. Intranasal enterostomy. It is performed to facilitate the drainage at the conclusion of an operation performed. It is used to close an oroenteral fistula or to remove a tooth or a root from sinus. The drawbacks of intranasal enterostomy: it is controversial surgical procedure for the following reasons. It cannot drain the sinus satisfactorily as the point created for drainage is not at the point of dependent drainage due to the fact that enteral floor is about 1.5 mm below the nasal floor. It also interferes with ciliary pathways, thus impedes normal physiological drainage of sinus. Thank you so much for your valuable time.